afternoon, everyone, and welcome back to the Brainy Boomer Lecture Series. We're so very happy that you've all joined us today. We would like to begin by acknowledging that the McGill University Research Center for Studies in Aging is located and our work is done on unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of the lands and waters on which we gather today. Tiohtià:ke, commonly known as Montreal, is historically known as a gathering place for many Indigenous peoples. Today, it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future, and our ongoing relationships with Indigenous and other peoples we serve within the Montreal community. In 2007, the McGill University Research Center for Studies in Aging, or the MCSH Education Committee, started the Brainy Boomer Lecture Series in order to suggest practical steps to both improve and maintain brain health, as well as to promote healthy lifestyle choices amongst the most populous generation in history. The MCSH Education Committee, which was founded in 1996, has three main objectives: identifying education needs of healthcare providers, seniors, caregivers, and the public, and to develop responses to meet some of their needs; to enhance the positive image of the aging process by addressing stereotypes and myths about aging; and finally, the dissemination of research on aging. Dr. Wendy Chiu is a geriatrician at the MUHC-Montreal General Hospital. Her work involves multidisciplinary geriatric assessments and rehabilitation with the goal of helping frail elderly live at home as independently and as safely as possible, and with the emphasis on patient and caregiver quality of life. Before continuing, we would like to remind you to please mute your microphone on Zoom, and that if you have any questions, you can either write them down in the chat box on Zoom, or you can wait until the end of the conference to ask them directly. And now I'd like to invite Dr. Chiu to start her presentation.
Good afternoon. Thanks so much for this opportunity to talk today. Just to give you a little more background on me, I'm a clinical geriatrician, so care of older people, particularly in the outpatient setting. So that's in clinic, outpatient rehabilitation. But with COVID, I've been doing more and more consultations in the emergency room and for people who are hospitalized, who are admitted to the hospital. And when I heard about this series in terms of, promoting healthy aging and prevention and trying to do things that can promote our lives as we get older, I thought this would be a useful topic in that it comes up very, very often, both for people asking themselves as well as family asking, am I safe to live at home? Okay, because in the words of Dorothy clicking her heels there's no place like home. Well, what does exactly that mean? And how can we maximize our chances of that happening? Ultimately, at some point, all of us, something will happen to us. This is not an age-related thing. This is health. This is nature. But what can we do to favor our staying at home if that's indeed what we want to do? So there have been various surveys and so forth, and there was one from the National Institutes of Health, Ryerson University, and saying that Canadians over the age of 65, I think this was mostly in Ontario, like 90% of them want to stay at home as long as possible. So, a lot of people are saying they want to do that. What does that exactly mean? How can we make it happen? And this is going to be a little bit of a more philosophical talk than research. I have no conflicts of interest to declare. And if I happen to mention any private services or medications, it's just because I slipped. So another way of saying staying home as long as possible, the catchphrase you hear now is called aging in place, staying in my own home as long as possible. You also hear the catchphrase successful aging, and I just put here as an example a book by a McGill professor here at the Montreal Neurological Institute, who actually wrote a book called Successful Aging. But generally, when you talk about successful aging, it's some combination of this, where we're staying pretty healthy, we're staying pretty active, and we're still engaged with life. That's what most folks are defining as successful aging. What I like, though, is that Dr. Levitin goes a little bit further in saying, okay, listen, there's two things that kind of lead us to aging successfully, if you will. Some of it has to do with stuff that's happened in the past, genetics, etc. Water's under the bridge there kind of thing. But a lot of it also has to do with how we respond in the here and now. How do we change our habits in the here and now to promote success? And whatever your definition of success is, because it can vary quite a bit, you know, asking a 65-year-old, you want to stay in your home forever. Success is like, I stay in exactly the state I am now, and my home stays exactly the way it is, and so forth. But with time, with health changes and so forth, success, the definition of success may change. You know, I'm happy, I'm at peace in my home, I'm comfortable in my home, or otherwise. You know, staying in your home is commonly cited as successful aging, but just because you cannot stay in your home doesn't mean it's not a success. It just means perhaps the definition of success has changed over time. But the key point that I wanted to make, though, is that there is a huge amount of it, though, that's related to how we respond, okay? Hence, potentially under our control. So staying at home, what does home exactly mean? You know, home, it could be, you know, the physical space, the house, it's beautiful, it's on a hill and so forth. But that physical space is also familiar, it's comfortable, it's private kind of thing. I think that's when a lot of people speak of being at home, they're talking about that aspect of home, the physical space. But also talking about the psychological meaning of home. You know, that old expression, home is where the heart is, right? Where you feel happiest, where you feel at peace. The house may be a symbol of the achievements of your life's work kind of thing. And it's a symbol of healthy pride, if you will, of what you've done. Obviously, there can be a lot of memories. You know, this is where I raised the children. This is where I lived with my wife for 50 years. This was the family home for 3 generations, as well as being surrounded by objects that carry a lot of memories, a lot of sentimental value, no question. I would add then, though, that home often also means control, where I have a sense of control over my own life, over my own destiny. You know, the schedule is my schedule. It's done my way when I want to do it. It preserves my dignity because I am preserving me when I do that. And I think all of the above are equally important when we talk about, or when a person tells me that they want to stay at home, all of these elements. And so in my mind, and I'll show you in more detail in a moment, I have to process these kinds of things because this is what a person is telling me is important to me. This is what matters most to me. Okay, how are we going to make that happen? So how we make that happen comes to the staying part. You want to stay at home? Well, how do you stay? Various models, but most of them involve a model where it involves issues related to the person, issues related to the place, and issues related to supporting the person in that place. So person has to do with the health issues, has to do with, when they say activities, meaning their abilities to function in day-to-day life, functional abilities, has to do with finances as well. I'll be quite frank, and we'll come back to that. Place has to do a lot more with the physical environment in terms of accessibility. That is, you know, if you're can't do stairs, there's no stairs kind of thing in terms of it's accessible, as well as within the community, that the community resources you need are accessible in your area, if it will. And then the support in terms of home care services, other community organization services, family, friends. This is the kind of stuff, the gross domains that have to be looked at in order for somebody to stay at home. Maybe I'm getting a little bit too philosophical about this, but I also think about, what does want mean? You know, when you tell me that you want to stay at home, I understand. Staying, we've got to look at the logistics of that. But what do you mean by wanting? Because wanting can mean a lot of different things to people. And accepting can also mean a lot of different things to people. So when a person says, I want to be in my home in XYZ state, in my current state, a lot of it has to do with what level of risk is a person comfortable tolerating. Okay, so you often hear about things like, I don't know, financial risk tolerance. You know, are you somebody who puts all your eggs under your mattress, or are you somebody who puts all your eggs, all your money into stocks with the fluctuations and this and that? The same thing with any kind of decision, and wanting is a decision in life, is that how much risk can you tolerate? And not only how much risk can you tolerate, but how much risk can your family tolerate? Can the healthcare professionals, the system around you tolerate? Because that sometimes becomes the sticking point. Risk tolerance has a lot to do with personality, I think. You know, if you were a hang glider, bungee jumper, your whole life, stock market player your whole life, and now somebody's telling you, well, you know, there's a risk of this, that, and the other thing, and you better do this and you better use that kind of thing, and you say, you know, I'll take my chances. You know what? Why should I be surprised? You know, if you're telling me that that's you to take risks in your life, okay, I understand that that's you, okay? But we also have to think, though, how dangerous is this risk, okay? Because if you're telling me, I love to go bungee jumping, excellent, that's great. If you're telling me I love to go bungee jumping without a rope, you know, I got some problems there. You know, my threshold has suddenly, my threshold has suddenly dropped a lot lower in terms of tolerating that kind of risk taking, right? And that's where you get into areas of competency. You know, is the person competent to make that decision? And I'll come back to that in a little bit, okay? Wanting also has to do, though, with perception of what the outcome will be. What is the risk? You know, what that, you know, you're telling me there's a risk of this. Well, what is the this? You know, what is that outcome? And there are factors beyond personality that may affect that. And just generally in the aging process, studies looking at, you know, surveying various communities and as they say, cohorts, as it were, groups of people, saying that as we get older, our willingness to risk the new friends, new neighborhood, new routines, new people involved, new doctor, starting all over with a new doctor because your other doctor retired or went AWOL during COVID, et cetera, okay? Our ability to tolerate that kind of risk for change of new becomes lower. We don't tolerate that risk as well. And as well as our time perspective, okay? If you're 20 and I'm staying at home and you see forever as your time perspective because, you know, you're in great health now, everything's perfect, whatever. If you're now living with illness, frankly, at any age, but particularly in older age, as you know, illness, unfortunately, does become more prevalent as we get older, but this is anybody of any age living with illness, our time perspective suddenly gets shorter. And so that if I have less time to do what it is that I want to do, which is to remain in my own home, I want to do everything I can to make it happen. So I will tolerate a lot more risk to make that happen. So those kinds of factors also come into play. And ultimately, what it all comes down to is what matters most? What is the goal? What do you define as quality of life? Because what one person defines as quality of life can be very different than another. What one person defines as quality of life at one point in their life can be very different than another point in their life. You hear this a lot, especially with, you know, without getting into a whole discussion about medical aid and dying, but a lot of people saying that, well, if I ever find myself in this state, you know, I can't walk anymore. That's it. I wouldn't want to continue. And then skip forward, you know, 10, 20 years, and they are actually in a state where they're having difficulty walking. But now that doesn't seem to be the big issue anymore. I gain quality of life through other things as well. And so the perception of quality of life changes. The flip side of wanting, though, is not wanting to move. Trust me, I understand this. It's so overwhelming to move, especially if you've been living in the same place and you've got like 30 decades worth or more of stuff with you. It can be psychologically overwhelming, emotionally overwhelming. It can be physically overwhelming. Just the actual packing can be difficult, as well as the cost. It costs too much to move. And I guess why I'm going through all of this, ad nauseum, is that when I'm understanding that these are factors in the decision of staying home or not, wanting to move or not, my job is to think of how do we address it? If that is the barrier to the decision being made, is there maybe an alternative that the person may or may not be aware of, that the family may or may not know of, that could resolve the decision for now, at least, until such a time that other things can be arranged, So if you're saying that it's too hard to pack, well, there are companies that will do A to Z, you supervise, make sure they don't break your stuff, but they are doing all of that. If it's cost too much, part of the moving expense is due to health issues, because you have to move to an accessible environment, to a residence or something. Part of the cost of the move is actually considered a medical expense for your income tax. Or if you have to leave an apartment, break the lease of an apartment because you have to move for health reasons, classically accessibility. The law here is that the landlord cannot hold you to more than 2 months of rent and allow you to break that lease, charge you maximum 2 more months of rent, and then you can be on your way. And that may take a letter from a medical professional and so forth, but there are ways. If that's the only issue, there may be ways around it. So I want to stay home. What is home? What is wanting? What is staying? Okay. The question then becomes, to me as a health professional, is it safe? Okay. So this is where I'm just going to tell you about my experiences, or our experiences, common experiences, so that you can think for yourself, does this apply to me? Does this apply to my family member, where staying at home is a question right now? Or the future me, what do I need to think about if this question comes up? The two most common barriers to staying safely at home that we see are related to cognitive impairment, classically the dementias, pardon me, as well as falls, recurrent falls. Okay. So in terms of cognitive impairment, there's really two areas. The cognition is not allowing the person to manage their health, their serious health conditions, adequately in a safe fashion. So, you don't remember, and that includes taking the medications as they're prescribed, so-called compliance with medications. If you're not taking your calcium, vitamin D, okay, because you're forgetting, yes, this may increase the risk of bone fractures from osteoporosis in the future, et cetera, but I'm not going to lose sleep over it right now. But if you're not taking your critical diabetes pills so that your sugar goes super high and you get all kinds of complications from that and confused and dehydrated and in and out of the hospital for the same issue, you're not taking your heart medications, you go in and out of water on the lungs, what they call heart failure kind of thing, there's a problem there. Because if that keeps going on, at some point, it may kill you. Okay, something may be bad enough to happen that even you go to hospital and things don't turn around. So that threshold of dangerosity, of risk taking, has just changed in my mind to consider there. The other aspect of cognitive impairment is dangerous behavior. And whether that's dangerous behavior, as I was alluding to, like medication management problems, danger to yourself, it can include as well danger to others. For example, repeatedly leaving the stove on, having set the fire alarm off, smoke, the fire department actually had to come kind of thing, forgetting to extinguish the cigarette and setting off the fire alarms with that. That's not only a risk to you, but that's a risk to people living with you, people living in the same building, attached buildings, et cetera, okay? So again, the levels of risk tolerance fluctuate depending on what's the issue at hand. Self-neglect. I I don't know if Caitlin just noticed this. I tied my hair back before I was going to leave my hair down. I tied it back. It looks still like a mess because I haven't cut my hair, I'll be honest, since last summer with COVID and everything. I just didn't bother to go, kind of thing. Who cares, right? But if a person is self-neglecting to the point where they're developing skin wounds, okay, or the home and is so, as they say in French, insalubre. It's so unsanitary that it's actually causing health problems. It's causing food poisoning. It's causing infestations. Not that infestations. I mean, infestation. You can 5-star hotels have bed bugs, right? But that there's certain things that may be more controllable. Okay, then this is potentially becoming dangerous to a person's safety. Another one is the so-called behavioral and psychological symptoms of dementia, where there are certain changes in how a person behaves or their personality, what they do, related to a cognitive impairment, a neurodegenerative kind of cognitive impairment. And it actually becomes a danger to themselves or others. So become very physically aggressive, attacking a spouse, because in the paranoia, the spouse represents something else, et cetera, okay? These come into my mind, is this person safe to stay at home? The other aspect has to do with recurrent falls. Recurrent falls because the environment is not accessible, and if it was, the falls would be less of a risk. And when I say falls, it's not just falling down and no big deal. It's falling down, breaking hips, hitting the head, getting a head trauma, bleeding in the brain, major falls, okay, injurious falls, as we say. It could be related to not having falls prevention equipment or adaptations or doing things in a way that could prevent falls. It could be related to not having the way to get help to prevent complications of lying on the ground after having fallen down and not being able to get up. There are complications of not being able to get up. If you're on the ground constantly lying on one side, the skin in that area is going to start to break down. The muscle that you're lying on is going to start to break down. And these can have risks of infection, kidney damage, all kinds of other things that can then lead, obviously, to much more serious conditions, including death. Okay? So if I have a person who is living in a completely non-modifiable home, who is refusing to modify the home, that could be modified, who is unable to remember to use a mobility aid, segueing back to cognition, or is refusing to use an adaptation that could prevent falls, or they're refusing to have a means to summon help. I've had patients where they have a cell phone. They know how to use their cell phone. They charge their cell phone. All you need to do is put it in a pocket, put it in like one of those little crossbody bags when you're walking around the home doing your things. You've got your cell phone on you. No. Why? Why are you saying no? Okay. So these are the kind of factors I got to think of. Are you safe from a cognitive point of view? And are you safe from an injurious falls point of view? Many other reasons, but those are the two most common reasons. You can also be unsafe through no fault of your own or the person. They or you may do everything that's recommended, everything that's suggested, okay? But there's still a mismatch between what your needs are and what the resources out there can provide for you. And the resources out there include formal healthcare resources like the CLSC and things like that. It can also include family. Say all your family lives away, kind of thing. Or your own family is sick. I was just speaking to somebody yesterday. Her daughter would help taking care of her husband, the daughter's father, except the daughter just got diagnosed with breast cancer and is about to go through a round of chemo and mastectomies and so forth. Okay. There is a lack of the equipment or the adaptive aids, even though we know what you need, it's just not available. Either in the system, it's not affordable, there's wait lists for it, etc. And finances, I'll be honest with you. I remember a person saying, money doesn't buy you happiness, but it sure helps when you're sick, okay? Knowing that there are limitations to our system, whether it's our so-called universal healthcare system or somewhere where it's clearly a payer system like the States, finances do make a difference. Okay, because for example, you lack equipment because the system doesn't have it, the CLSC doesn't have it. If you have the finances to buy it or to rent it, that may make the difference between you being able to stay home safely and not. Okay, so if you don't have enough finances, what can you do? If you are, say you're still working and you're deciding, should I retire now or should I wait till I'm 71 so that I can get the full pension or not, or whatever, consider that, one of the factors to consider is, will I have enough finances if I need more help that the system cannot provide? It's a very sort of nihilistic way of thinking. You don't want to be thinking about, do I have money for when I'm sick? But that's reality. Okay, so if you're looking at other factors like my quality of life, I want to spend more time with my family, I want to spend more time traveling, et cetera, consider also, I would like to have more money so that if and when I need more help, I have the finances to do it. The flip side of that is people who do have the finances, but who choose not to spend. Okay. Saving for a rainy day, it's pouring, spend, because if you're telling me what you want is to stay home and what we need to do is to spend a little so that you can do that, it's worth doing. Okay. Also a big mismatch though, and I was alluding to lack of CLSC or family, is lack of a primary caregiver. So somebody who is there when you cannot do it yourself, to coordinate your care, to advocate for you, to ask the questions, to call around for the services, to call when there's a problem, to observe when there's an issue. Those kinds of things are sometimes the difference between a person being able to stay home or not. Similarly, I'm saying the caregiver status is compromised. So like saying the daughter is about to have health problems herself, the spouse is in major depression and can barely take care of himself, let alone his spouse, kind of thing. If the caregiver is not well, that's almost the equivalent of lack of a primary caregiver. I've seen situations where there are two people who have pretty much exactly the same illness, the same severity of illness, but one has a caregiver and has finances, that person's staying home. The other person doesn't have a lot of personal finances, doesn't have somebody as a primary caregiver. That person, we're talking about relocation and placement. Okay, that's how important the presence of an able caregiver can be. So now I've got all these kind of factors running in my head. What does the person want? What are the factors that we need to make that happen? Is this person actually saying something that is feasible and safe? Okay. And now what feasible and safe means depends, as I mentioned earlier, on risk tolerance. Okay. It also matters on what exactly is your goal. If you have a terminal illness and your goal is to die at home with palliative home care, okay, then let me see how we can work the system, how we can work things with equipment and other funding and other organizations and so forth to make that happen. If you're telling me I would want to stay at home because I want to stay at home, period, I don't want to discuss it, okay, now I got to wonder, is this really an informed decision? Are you really making a competent decision? Okay. And what's involved in assessing a person's competency to do anything, frankly, whether it's so-called informed decision-making, is the person choosing appropriately to take or not take that medication, to do or not do that job, take that promotion, whatever kind of thing, all the thinking that has to go behind that. The same thing for decisions like, do I stay home or not? Do you understand why people are even questioning this, why this is even in discussion? Do you understand the risk benefits of staying at home versus doing whatever is being suggested to you? If you're disagreeing with what's being suggested to you, what are the alternatives that you're proposing and what are the risk benefits of those alternatives? and to be fairly consistent in your choice. You can't be one day this and one day that and one day something else. Like then we're going to wonder, what are you really thinking? Like what's going on in your thinking pattern there, okay? So if you clearly understand something and you're saying that I tolerate this risk and I understand that this may happen to me and that it would be, this may not happen if I do this and blah, blah, blah kind of thing. And it's something that's within a threshold of dangerosity that healthcare professionals also feel is a tolerable risk. That's a big if. Then we're going to say, fine, how do we make it happen? Okay. I'll be honest with you. I've gotten into discussions, shall we say, we won't say conflict, but discussions with colleagues about what one colleague is willing to tolerate to say this is safe or unsafe, and what another colleague may be saying, listen, it's not great, it's marginal. This is a little bit of a pejorative term you sometimes hear being used, but there are probably people out there living like that anyhow, and we're not going around and declaring them incompetent. So why are we doing that in this case? So again, these are the ideas that are going through my head as a healthcare professional, and that dangerosity thing. Let's have a sliding scale. If you're saying that you don't want your calcium pill, if you're telling me that you don't want your insulin, okay, there's a scale there. And all of this kind of comes down to something that we're taught, when we take the Hippocratic Oath and all that business, is that we're supposed to act ethically in the best interests of the person, as well as trying to respect what the person wants as much as possible. And so we talk about respecting a person's autonomy, what they want, as much as possible, offering things that we feel can genuinely help them, and non-maleficence is the first do no harm thing that we don't think will harm them. Okay, this is where I'm trying to weigh all those things that I was talking about earlier. But at the same time, I am a healthcare professional with a responsibility to society. And I have to think about, from a societal point of view, is this logical? Is this safe? So if you want to stay home at all costs, but you've caused already 3 stove fires and you've got 6 other tenants in the building, I got to say, you know what? Your autonomy there, the justice to society, safety of others may outweigh your autonomy in that kind of situation in the competency assessment. On the flip side, though, if you are eligible for certain services or certain equipment and it's not being provided to you, my role as somebody looking at weighing all these factors, these ethical pillars, if you will, is to advocate for you to say, hey, CLSC, hey, system, we need this. We need it now. Okay, this is a priority. This is why, et cetera, et cetera. And we sometimes do that. We're sometimes making multiple phone calls, or we're writing things, in a way to express why we need it so urgently, triaged higher, et cetera, et cetera, et cetera. Okay, this is part of our responsibility as well to a person. So some of the things we try to do to help a person stay at home. In the medical assessment, we diagnose and try to optimize the medical conditions, like physical health for falls prevention, like mental health for cognition and mood and so forth. Substance use comes into play here as well, counseling people on alcohol reduction or cessation. Optimizing medications. I've had people non-compliant with the medications, multiple hospitalizations because of non-compliance with medications. And I look at their medications and holy smokes, like it's complicated. There's like 6 pills there. I don't even know why they're taking it. This one, you're supposed to take it half an hour before breakfast. This one you take with food. This one you take 2 hours after taking that one. And it's 4 times a day and blah, blah, blah. And like, if that's the only reason that somebody cannot stay home because they're not taking their medications in a way to stabilize their health condition to stay out of hospital, what can I do to simplify these medications? Can I de-prescribe, take away things that are not critical? Because if the goal here is to stay at home, and what's better quality of life is staying at home than taking these pills to prevent something in a few years, Okay, I'm going to favor ways to stay at home now. Can I simplify how many times a day? So instead of this medication that needs to be taken 3 times a day, can it be replaced by something that's a long-acting format just once a day? Okay? Or not? Maybe it can't be. Maybe there are medical reasons, biological reasons it can't be, but I got to think, can it be? If I have it in a pill dispensing system, like a pill box, a pilulier kind of thing, could that make it easier? Timers, setting an alarm on your phone kind of thing, or family members doing that. A friendly call from a community organization, from a family member. You know, your sister in British Columbia, if you organize this, can make a friendly call at this time of day and say, by the way, did you take your medications? You know, whatever works, okay? Because if that's the goal of care, that's what you want. That's what matters most to you. How do we make it happen? Sometimes we'll even ask CLSC to send a person to make sure that the medications are given, if that's the only thing or the main thing that's preventing the person from living at home. We then try to see what it is that the person needs in order to compensate for it. We need to do so-called functional assessment. How does the person function? Are they capable of functioning in day-to-day life to stay at home? The things that they can and cannot do, whether that's to just basically survive, okay, to be safe, which is kind of a little, you know, I don't want you to just survive, I want you to be safe kind of thing, or even to thrive. Okay, I don't want you to just survive and be safe. I want you to be happy kind of thing. So what are the kinds of compensations, adaptations, whatever that we can make? Now, sometimes what it is if you tell me what's more important to me than staying home is seeing my friends and being happy, but you're in a state where you cannot get out of your home, therefore you do not see your friends. And if that's what you're saying makes you happy, it might actually be more of a success to move to somewhere where you can get out of the home and go see your friends, or even better, move to a place where your friends live. So I have one a woman I was speaking to recently where it's getting harder and harder in her inaccessible apartment. Well, her friend, her best friend, who she'd love to see if she could get there, lives in it's not a residence exactly. It's kind of it's an apartment building. It happens to have a lot of older people living in it, but it's an apartment building. But it's got an elevator. It's got no stairs. Nothing. The grocery store is like right next door, and that kind of thing. Maybe moving is the way to thrive and the way to make you happy, if that's what you're telling me. It's not just staying home, it's being in a place that I would be happy to call home. Sometimes that involves referring a person for rehabilitation. You know, if we want to prevent those falls, if we want to learn a new way to do something, that involves rehabilitation. And then, of course, mobilizing the system formally and informally for actual hands-on help in the home. So along those lines, and coming back to that justice, that social justice kind of thing, is working the system, mobilizing the system. And that can include, obviously, the things like home care, as I said, the physical adaptations, for example, asking for a professional, an occupational therapist, to go to the home to see, okay, if we modify this or that, that'll lower the risk of falls, everybody's happy kind of thing. Making sure that you have the transportation that you need. If your health condition or your family member's health condition no longer allows them to drive, there's no question that when you can't drive, it's a huge change in your life, your quality of life, your spontaneity of life, and so forth. How can we try to compensate? It'll never be perhaps as good as, but doing it differently so that you can still get out where you need to go, where you need to do the things you need to do. And that competency assessment that may factor into all of this. So I put a little spade over here because this is going to be politically incorrect, but let's call a spade, okay? I hear people telling me, I want to stay home. I don't want to be a burden, but, okay? I don't want to be a burden. Well, what does that mean exactly? Or I hear people say, you know, I don't care. Even if I die, I want to stay at home. Even if it means that I'm going to die, I want to stay at home. okay? So I got to go back and figure out, stay, want, stay home. What do each of those mean to you? What is the goal here? What is it that matters most to you? And see, okay, maybe it's a question of just changing, reframing things, mobilizing the system, adapting things, et cetera, all those things that I talked about. But sometimes it means that a person really needs to reflect, okay? Being a burden doesn't just mean you help, because oftentimes people do want to help. They really do want to help. They're offering their help, but sometimes they just need to be told what to do or when to do it, or that kind of thing. But there are other times where people cannot or are not comfortable or just don't want to do it, whatever it is that you need, okay? Particularly if you or your family member potentially could do it yourself if you accepted help, kind of thing. That's a burden, okay? That's when you're asking people to do things that potentially you could do yourself if you just change the way that you do it. And whether they cannot do it because they're undergoing chemotherapy and surgery themselves, whether they're not comfortable doing it because the son is extremely uncomfortable to bathe to see his own mother naked, to help her bathe, or they just don't want to do it for whatever reason, okay? Then you got to really question yourself, question your decision at that point. What is the impact of my decision on other people? Okay? Not politically correct for me to say this, but I'm going to say it because there are times where a person could stay at home and safely and possibly even thrivingly happily, if just accepting to make small changes. And this is where I talk about the paradox of accepting help. The paradox of accepting help. Many people feel accepting help, using a walker, allowing somebody to come into my home to help me bathe, means I'm giving up, means I'm handicapped and I'm showing the world that I can't do it. I don't want people to see me with a walker, kind of thing. But the paradox is that the opposite can often be true, is that it actually makes you more independent. And I always remember this one woman, amazing woman, who had horrible arthritis, really advanced osteoarthritis in her hips, her knees, and so forth. It was so bad. When you hear your knee cracking a little bit when you're walking, kind of thing, you could hear her hips cracking, okay? You should not be able to hear a person's hips. That's how bad her arthritis was, okay? But she absolutely refused to use a walker. She would use 2 canes to go out. And she came and told me one day, says, I love Montreal, wonderful young man. He ran across Sherbrooke to help me with my grocery bag. Isn't that great? And I'm like, Mrs. So-and-so, he may be a wonderful young man, but the reason he probably did that was probably he saw you, and I didn't say it this way, of course, but basically hobbling with your 2 canes. Whereas if you had that walker the physiotherapist talked about, which has a basket in it where you could pile in all your groceries, you would be tootling down the street and nobody would notice any differently. It would actually make you more independent, okay? So I know I'm going on and on and on about this, but if one really wants to stay home, all those other factors, be clear about what you want, see if we can make it happen, but also be aware that our choices do have consequences, and to consider those consequences as well on yourself or others. By the way, if I want to get super incorrect here, I don't care if I fall and break a hip, I'll die at home. That might not be a very pretty death. Okay, it doesn't mean that you just fall asleep like in a Hollywood movie. It may entail suffering. Okay, I don't want you to suffer. If it's as simple as wearing that cell phone, carrying that cell phone with you, or wearing one of these help alert button kind of things that calls, whatever company, or calls your family member or whatever if you need help. If it's something as simple as that, and you're refusing to do it because it's going to show I'm giving up, then there can be consequences. Flip side of this is a caregiver, as a family member saying, I want to take them home no matter what it costs. It's all the same kinds of issues. Fine, make the setting adaptable, adapted, et cetera, whatever the recommendations are. If it's causing you to burn out, we often say if the captain of the ship goes down, the whole ship goes down, right? If the caregiver burns out, it's like the whole scenario burns out, okay? And not to be mean, but if my immediate responsibility, the name on the chart is that person, and you are part of that person's care, it is my responsibility to then make sure that you, caregiver, are okay as well. Okay? I'll give you a caveat to that, though, a flip side to that. So I had a very I had a family member who I was primary caregiver to for a long time, who had very basic care needs, just walking and at a certain point eating and so forth. And the CLSCs, the healthcare professionals, they would say, okay, we're going to send you home help. We're going to send you help for bathing, blah, blah, blah. Okay. And I was reluctant, stranger in the house. My family member was reluctant. I don't want this person to see me naked. But gradually we worked out a routine and we got to know the people who were coming. And I always remember one of them, he would wear like a leather vest and tattoos and piercings and whatever. You'd be scared to meet him in a dark alley, but he was the nicest guy. He would come, he would talk to us about his Chihuahua, how much he loved Madonna music, which is just weird, but anyhow. But once a month, he would not be available. And so the CLSC would send somebody from l'agence. Okay, they would send this person who doesn't know us, doesn't know my family member's health condition at all. And it'd be like starting from square one. I'd have to reorient, and here's the things, and here's that, and here's how we position, and blah, blah, blah. And that actually made more work for me. It didn't give me respite, it added to my stress. So I told the CLSC, I said, listen, I understand why this is being offered, but it actually adds to my stress. If it's not the regular person, please don't send anyone. And they're like, okay, we get it. Okay. It's not just me saying, no, I don't want anyone. It's this is why I don't want anyone. It doesn't actually help me. Okay. Caregiver, though, you got to understand there are limits to the system, right? There are wait lists. And if you tell me no matter what it costs, then there may be costs. And whether those are financial costs, so it may mean you have to spend. It may mean if you want to remain together at all costs, it may mean selling the house so that you can liquidate finances, so that you can afford what you need to remain together in the community, et cetera, okay? It may mean, for example, adult child, that you may need to take time off work, that you may need to take a leave of absence, that you may need to move back to Montreal. If you're telling me no matter what it costs, there's always a way to do things. The question is, what is an acceptable way to do it for people involved? And the self-care, as I mentioned earlier, got to keep the ship afloat. Okay, so what can you do? It's issues related to the person. Keep active physically, mentally, socially. Prevent falls. Keep your brain as sharp as possible. Those are the two main factors that jeopardize a person's safety to stay at home. Be informed about your health, your medications, advocate for yourself, adapt your environment, consider changing your environment, whether that means moving, whether that means equipment, and at least try. If the CLSC is offering you equipment or services, it is a lot harder to get those things than it is to cancel them. So what I urge people to do is, okay, it's not ideal, but try it out. They're offering to help you with the bath. Try it out for a month, once a week. That's 4 visits, okay? Try it out, see how it goes. And if you find out, as I did in my family member's case, that actually it was kind of helpful because it literally was physically heavy lifting for me to do, and it did actually help physically, my back. I tried it out and I was like, okay, this is worth continuing. But if I try it out and it's really, really not working, tell me why it's not working. Let's see if we can change it, or if need be, cancel it, okay? And those supports. Make sure that you're surrounded, make sure that you're linked with your healthcare system when you need to be linked. Be proactive by anticipating changes. So say now you are living in your multi-story house, the market is still hot. You're thinking, I'm gonna sell my house, it's a great time to sell. What am I gonna move to? Well, I have arthritis. It's been a little less easy for me to walk. Am I going to move to another house, a beautiful condominium, but it's on a 3rd floor walk-up building? Or maybe I should move to a place that is accessible. Maybe I should move to a place where I know the grocery store and the bank and the pharmacy and the bus stop and so forth are all within close proximity, because by anticipating those needs, you'll actually stay independent longer. So I give you a whole bunch of resources here that you can take a look at, and I can provide this these slides or these resources later on. Or if you have your phone with you, you can just quickly scan the QR codes there to get immediately to the websites that are listed there. But this is from the Government of Canada, where they literally have checklists. Literally have checklists of all these things. What are issues about my health that I need to consider? What are issues about my home setting, my community, my connections, my family, et cetera, to maximize doing what it is that I want to do in this talk, staying at home. Preventing falls, there are various programs, both sponsored by the community, things that you can do yourself, community organizations to try to prevent falls. It's really a big issue. Keeping your brain as healthy as possible, one of the reasons that you're listening here today. And this is from the Alzheimer's Society of Canada. They actually have a lot of nice tips and tricks here, kind of thing. I have a friend who decided to download an app on his phone called Hello Chinese and decided to try to learn Mandarin. He's asking me questions. I can't even answer the questions. But anyhow, that kind of thing. Keep your brain busy, Keeping active. One of the benefits of COVID was realizing that the community organizations and gyms that people used to go to were now closed. So how could we help people keep active within their own home? And public health organizations, Health Canada, they've developed all kinds of programs that can be done within or outside of the home. This one is particularly interesting from Public Health of Quebec, where they have programs geared towards people who are already quite active, and they have programs adapted to people who already need assistance to mobilize. But no matter what your level is, there's keeping active, there's always a benefit to doing it. And keeping that brain healthy, keeping physically active means keeping socially connected. A lot of us have already become socially disconnected because people have moved away, our friends have died, whatever, community groups with COVID, they all closed and we all got isolated with that. It takes effort, but it's worth it because there is research upon research that shows people who are socially connected have better outcomes, fare better, including things like staying at home longer. So I'll end off with just this one more spade of the concept of being resilient. The wind is blowing hard, your health has hit a crisis. If you try to stand your ground and say, no, 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 this is the way I want it, your bow will break. But if you can say, this is the way I want it, but I will try it this other way and see how it works out, you may be the palm tree that stays standing through the storm. Okay? And not that I'm trying to push pithy expressions or religious ideas on anybody, but I have to admit, I really, really do like the Alcohol Anonymous saying of having the serenity to accept what I cannot change what I can change, and know the difference between them.